Good morning and welcome to the Narrative Justice and Global Healthcare Policy event. This event is being produced by the Society for the Psychological Study of Social Issues and is being co-sponsored quite graciously by the Mission of Kuwait to the United Nations. Before I tell you very much more about SPICY, I would like to introduce the SPICY United Nations team, which is behind me, and each member maybe just share your name and say hello.
Start.
Okay. Hi, I'm Elizabeth Zick. Hello.
Hi, I'm Rachel Cortez.
Hi, I'm João Carvalho.
Hi, I'm David Paicedo.
Hi, I'm Suzanne Yates.
Hi, I'm Ben Saunders.
Fantastic and outstanding. Good job. Good job. So who is SPICY? SPICY, as I said, is the Society for the Psychological Study of Social Issues. It was formed in 1937. It has over 2,000 members worldwide. They are primarily psychologists, but also include social workers, sociologists, and other professions. SPICY has been involved at the United Nations since the 1940s, since the start of the United Nations. You can read, and in fact, our main journal, the Journal of Social Issues, ran several articles about the fledgling United Nations back in 1947, talking about visiting the first UN location out on Lake Success on Long Island. In the 1950s, SPICY was involved in conducting quite a few research projects for UNESCO on prejudice and discrimination. In the 1990s, SPICY's United Nations team was formed and received accreditations from both ECOSOC and DGC, the two accrediting bodies for NGOs at the United Nations. SPICY UN team members have been involved in the development of Psychology Day at the United Nations, which has been an ongoing event since the 2000s, as well as the Psychology Coalition of Accredited NGOs at the United Nations, a collection of over 10 psychology NGOs which are accredited here. Also, currently, members of the SPICY team are active with the Global NGO Executive Committee, also on the Board of Congo, and we regularly program events for various commissions, including the Commission on the Status of Women, Population and Development, as well as the high-level political forum, which is held here at the UN in July. We have three committees as part of the United Nations team: anti-racism, climate, and LGBTQ. Today's event is the work of the Anti-Racism Committee, and we'll introduce the lead of that committee in just a moment. I want to express again our thanks and gratitude to the Mission of Kuwait, which has been very active in the area of neurological diseases and disorders, and health and mental health, which actually gel quite well with our topics today. So we thank them very much. Also, thanks to the Psychology Coalition at the UN for its continuing support. Today's topic is narrative justice and narrative medicine, which is one particular strategy for addressing severe disparities in the delivery of healthcare and mental health services to individuals worldwide. This inequity tends to be found along the typical axes of race, ethnicity, indigenous status, and others. This is, in a nutshell, you're going to hear so much more about it, but it's a fantastic approach to remedy these disparities that have been documented all over the world. And in fact, a number of SPICY members were involved several years ago in this great study of the provision of healthcare, a multi-site study of provision of healthcare and discrimination in situ. So it's really an important topic for us. Next up, Dr. Rachel Quintus, who is the lead for our anti-racism committee, will speak. Dr. Quintus.
Yeah.
You, our audience today, are overwhelmingly either healthcare policymakers shaping health systems at the national and global levels, or healthcare researchers and clinicians, people who are diagnosing, treating, and studying mental and physical illness every day. Our goal today in bringing us together is to share what current medical and psychological science tells us, to reflect on the stories about health and illness that shape our clinical decisions and our policy frameworks, often without our conscious knowledge, and to think collaboratively about how our systems are functioning and how they could be more effectively functioning in practice through those stories. We hope to spotlight the fact that what we think of as health, normalcy, and well-being aren't and have never been neutral. They've never been objective. Labels and stories have always had social and political power. They define who is credible, who is normal, who is deserving of care, and who needs to be eliminated or controlled. Our stories about what is important guide our attention. They direct our resources, and they help us decide who needs to be protected and at what costs. As a UN representative of SPICY, the 9th Division of the American Psychological Association, I'll give examples from our own country's history, but these stories are true. The impact of these stories are true across the world. In the 1800s, Confederate psychiatrist Samuel Cartwright argued that enslaved people who attempted to escape were suffering from a mental illness he called drapetomania, a psychotic desire to escape enslavement. The treatment, of course, was capture and beating. This was not fringe thinking. Cartwright was a well-known psychiatrist and an esteemed leader in healthcare, and probably the most famous of the students of the father of American psychiatry. In the early 20th century, Black patients were widely considered insufficiently sophisticated or verbally skilled for psychotherapy. In the 1960s, during the Civil Rights Movement, the diagnosis of protest psychosis was developed, a type of delusion held by African American people mostly, who are paranoid enough to believe they're being treated unequally by government and law enforcement. This was, of course, only a few years before the public discovery of the Tuskegee experiments. In the 1980s, there's a very famous study by Loring and Powell finding that when given the same exact patient blurb, with only one change, one patient was African American, one patient was European American, psychiatrists diagnosed the African American patient with paranoid schizophrenia twice as often as the European American, 100% times more often. Lest you think this is a pattern of the past, this study was conducted again about 10 years ago with the same results. To this day, we see our systems using race to define the story of other people's pain. One key area where we see this is neurological disorders. Medical disorders going disproportionately unnoticed, misdiagnosed, and untreated, particularly in people of color. We know that conditions like autoimmune encephalitis can present like psychiatric symptoms. They can present like psychosis. And early neurological screening can be life-saving because aggressive treatment is needed. However, patients of color in the US today are significantly less likely to receive that screening and more likely to receive primary psychiatric labels that will actively take away or risk their lives instead of comprehensive medical workups. We see Duchenne muscular dystrophy misread as ADHD or behavioral issues in Black children significantly more often. Catatonia is interpreted as aggression or noncompliance with treatment rather than a medical emergency. The labels and stories we tell as healthcare professionals matter because they shape our patients' trajectories, whether someone receives imaging or isolation, treatment or restraints, support or punishment. When certain communities are repeatedly framed as unreliable narrators of their own bodies, their pain becomes easier to dismiss. When behavioral explanations are favored over biological ones, screening becomes optional. When mistrust is pathologized rather than contextualized, the task becomes, for us as healthcare professionals, to minimize the harm or the risk that that mistrustful person poses, rather than to connect with or care for that person. We see every day how our diagnostic process and our public health procedures are deeply tied up in our narratives about risk, worthiness, and credibility. So as you listen to our speakers today, Our goal is to have you thinking about narratives. Who gets to tell our stories about who we are, what's happening in our bodies and in our minds, and what our difficulties are about? What stories do we tell about other people in our systems? Which narratives get made into values, laws, and policies? And how can we make those stories and systems more diverse, more accurate, more helpful, and more humanizing for everyone who needs them?
Thank you, Rachel. And everyone can sit down if you like at this point. Before we move into the program, let me invite those guests here at the Church Center. Across the street, there is the UN Secretariat. Let me invite those who are here to take advantage of the food that is arranged in the back of the room for you. Next up, David Calcedo will talk a little bit more about our narrative justice topic. David has been introduced as a representative of the SPICY United Nations team. We're so happy he's with us. He's also been a member of the SPICY Council. He is serving as a research integration officer at the Borough of Manhattan Community College, and he earned his PhD from the CUNY Graduate Center. David, come on up.
Good morning, everyone. Thank you for being here at the Church Center and attending via Zoom. I'm David Caicedo, a member of the SPICY UN team and a social psychologist in the City University of New York. I'll begin by paraphrasing Jerome Bruner with the statement, "All memory is storytelling." If I asked you how your weekend was spent, what would you say? You'd tell me what you did, who was with you, what the weather was, especially if you're here in New York. But then, if pressed, you'd perhaps add another layer, how you felt doing what you did, how the others, if present, contributed to those emotions, and perhaps abstractly or concretely, how the weather, the sun, the wind, the temperature, influenced that same experience. Narrative researchers investigate these interwoven features of lived experience, but they also add a hidden feature, sometimes hidden even from ourselves, the absence of or implied negation. What do I mean? If you know me well enough, I could tell you what I did last weekend, but in the same sentence, I could also imply what I wish I'd done without saying it. I went to the movies because it was too cold, but I wish I was outside in the park. I stayed at home and worked on a presentation, but I wish I was visiting my parents. Absence or implied negation suggests that I could tell you what I did, but implicitly I am also telling you what I didn't do. I could tell you who I was with, but implicitly I'm also telling you who wasn't there. This all may sound elementary, but matters complicate when we include the emotion or emotions that run through these presences and absences within the narrative of lived experiences. This is where the storytelling begins. Therefore, this narration is incredibly illuminating, but also potentially powerful. Individually powerful in its reflexive ability, where the individual adopts a distant view of themselves to be able to tell their story, but also powerful in its ability to dampen, distort, or silence stories. Delving in a little deeper, as narrative researchers would do, would bring us to questions such as, whose stories are silenced? Whose stories are dismissed? When and by which means does this occur? But also, what can a receptive ear do to validate them? Today's topic on narrative justice in global healthcare policy is precisely on these points, from the perspective of medical diagnosis, treatment, and care at the intrapersonal, interpersonal, and societal levels of understanding. Narrative justice, then, is an action-oriented framework that adopts storytelling as a way to counter the distortion and silencing of lived experiences, whatever their origin, with the objective to use those stories as a resistance and advocacy tool. The work of critical psychologists Michelle Fine and Colette Ayut, for example, have addressed power and structural inequities in global regions, such as South Africa and the former Yugoslavia, in order to improve the legal, social, and political systems that marginalized communities face. One of the most direct ways to engage in narrative justice and challenge injustice is the ability to tell one story. Agency must be embedded front and center in any initiative, small or large, to challenge dominant narratives that utilize misinformation, stereotypes, and dismissal as their tools. Unfortunately, dominant narratives use power and control to dictate the content and direction of stories, and therefore must be met with agentic force through one's voice. The work of narrative psychologists like Dan McAdams, for instance, has shown how a sense of agency correlates with positive mental health outcomes. By contrast, passivity, like that resulting from narratives of control, could be met with a fatalistic or inevitable outlook. It was meant to be. The thought and emotion of fear, also resulting from passivity, is particularly prevalent in dominant narratives, both from the speaker and the listener's point of view. My early work on the discourse of immigration debates in the US suggests that fear is both cause and consequence of a narrative of control that shapes perception at the interpersonal, and societal levels. My current work with Melissa Marcotte investigates the life stories of older adults and the life advice they share with young adults, particularly first-generation college students. One of the interview questions asks, "What's the most challenging thing about getting older?" I'll ask the audience, what do you think the vast majority of interviewees say? Exactly. That's correct. It could be said that these health-related responses reflect a sense of fear regarding the past, the present, and the future, and what they've experienced themselves, what they've observed from and with others, but also what they predict could happen. What could also be said about these two topics is that the individual desire to not talk, but also think about fear-inducing elements might prompt some to not want to talk about them, which only fortifies the dominant narrative. The work of liberation scholars and writers like Ignacio Martín Baró, Paulo Freire, Gloria Anzaldúa, Bell Hooks, demonstrated that oppression and exclusion must be met with resistance against the prevailing sociopolitical structures. This resistance stems in part from personal narrative and collective conversation. Thank you for joining us in this conversation.
Before we move on in the program, we would like to take care of a small technical challenge. How close we can get. And we need one. What don't we need? That you, David.
But the one with the image is this one. Yeah, it would be the other one, the orange David, this one.
Yeah, orange tape. Yeah, that's.
Says it here.
So no.
So that's here.
Can we check the monitor?
Yes. No.
And I think we are back and ready to move ahead. So if one can deal with technical issues, one can deal with many of the world's challenges. Those of us who have worked on Zoom. I have the privilege of introducing Sayantani Dasgupta, Dr. Dasgupta, who is going to share, who is our keynote for today, discussing narrative justice and narrative medicine. We're extremely happy to have her. She is on the faculty of Columbia University and heads up the narrative medicine program there, as well as Sarah Lawrence. Yes. No, I'm sorry. That's okay. All right. Sorry. Well, moving on. She is a graduate of Johns Hopkins and Brown, and has published in a number of notable medical journals, including JAMA and The Lancet, as well as articles pertaining to motherhood. And in fact, she's the author of a number of books. And she shared with me that she did write a book with her mother while she was in college, and you weren't estranged. You were able to move past. That's great. That's great. That's fantastic. We're really privileged to have you here. And so without any further ado, Dr. Dasgupta.
Thank you so much. And thank you all, the UN SPICY team who's coming up to the UN SPICY team. So I really appreciate that. Let me just see. I just need to pull up my, there we go. So I can see it as well. There we go. So thank you all very much for having me, UN SPICY/SPICY team. It's a deep privilege to be in conversation with you. And my hope is just that we begin a conversation today. I'm not coming necessarily with definitive answers, but rather just some guiding questions and some frameworks. So as you heard, I am one of the founding faculty members in the program in narrative medicine at Columbia, where I also teach in the Center for Ethnicity and Race and the Institute for Comparative Literature and Society, which houses our medical humanities undergraduate major. And so I'm a pediatrician who's an academic, who's also in a different part of my life, a children's writer. And when people ask me how these careers fit together, I will usually say that in each aspect of my career, I am engaged in the work of health. When I saw patients in a clinic, I was engaged in the work of bodily health, corporeal health. In the classroom, as many of you are in classrooms with undergraduate and graduate students, we are engaged in the work of intellectual health. And as a children's writer, I really feel like my work is in the space of emotional and imaginative health of young people. But today I will be, and nothing is moving forward. Let us I might need technical assistance. Is there something special I should be doing here? Move my screen forward. I apologize, those on Zoom.
How many PhDs does it take?
Exactly. Exactly. Okay. Lovely. All right, that moves forward. So I just need to hit that. Okay. Okay. So what is narrative medicine? The faculty members in the program will have as many different answers as there are people. My answer is as follows. Narrative medicine is the clinical and scholarly discipline invested in the role of story in the healthcare encounter. And so the notion is that if we human beings are storied creatures, if we understand ourselves and one another through story, then those stories become all the much more important at moments of life's transition, including interruption, illness, trauma, etc. And if that is the case, then the receivers of those stories must be deeply trained, deeply prepared to elicit, interpret, and act upon those stories. We would never graduate somebody from a healthcare profession, from a psychology, clinical psychology program, or social work, or nursing, or medicine with a rudimentary knowledge of, let's say, anatomy or pharmacology. We should not be letting people out of these educational spaces with anything other than a really rigorous training in story. In the narrative medicine program, we talk about attention, representation, and affiliation, but we can really think in lay terms about eliciting, understanding, and acting upon stories. We're good. My own specific work tends to be at the interstices of narrative, health, and social justice, in specific around US-based issues of healthcare and race. And so, I do foreground this talk. We'll be delving into some global health justice issues with the fact that most of my work really is US-based. And the one thing I always tell my students is that although we are in this program called the narrative medicine program, although we, really focus on the importance of story, I also don't want us to be too precious about stories, because stories are, of course, not inherently just. We can think about the precursor to ethnic cleansing, genocide, violence against immigrant communities as being preceded by a really compelling story. Neighbors, friends, and colleagues being transformed into invaders, criminals, infestation, what have you. As the novelist Chimamanda Adichie reminds us, stories matter. Many stories matter. Stories have been used to dispossess and to malign, but stories can be used to empower and to humanize. Stories can break the dignity of a people, but stories can also repair that broken dignity. Although I won't be talking about this as much in this talk today, one of the things that I've been working on as of late is, in fact, the right to opacity, Edouard Glissant's framework of the right to opacity. The notion that particularly in these moments of deep surveillance that we are living through, that perhaps for marginalized communities, not telling, not being engaged in story is actually a really important space of resistance. So acts of opacity, especially in a state where state national security is framed as transparency, right? We turn the inside out, says Rachel Hall, who's a surveillance scholar. And so in those spaces, opacity can be a form of resistance. But I won't really be looking at that as much today, although I'm happy to discuss that later. Today, I'll really be giving us some frameworks to train for listening, to train for specifically listening across power in both medical spaces, so in both one-on-one intersubjective encounters, and public health spaces. So when we are listening to individuals as well as listening to community stories. When I came into medicine, particularly when I became a medical educator, interested in the work of, or the intersections of race and health, narrative justice and health, people said to me, oh, I know what you're career is going to be in this thing called cultural competency. And of course, there are, some really important things that this framework does for us in healthcare. Yes, cultural competency is a way to train clinicians to serve diverse populations. It can be a way to decrease medical errors. It can be understood as behaviors, attitudes, and policies that organizations adopt to work effectively in cross-cultural situations. However, all that said, how do we train for it, and what do those training frameworks reveal? Because, I apologize for this terrible image at the bottom. When I was in medical training, and this is not hyperbole, I was given a list of 10 things that Japanese Americans believe, or 12 things that Dominican immigrants use. And when I memorized and was able to reproduce those lists, I was deemed competent in caring for those communities. It was a traits list approach. We have moved away from that approach in training somewhat, right? I have some knowing nods from various people here. And it's, as this terrible image suggests, what I have facetiously been calling the "it's a small world" approach to cultural competency training. Arthur Kleinman, who we'll be going to several times for some reason, this talk is a very heavily Arthur Kleinman oriented talk today for some reason. The anthropologist and psychiatrist and his colleague Benson in 2006 talked about the problems of a cultural competency approach. And I think these criticisms, still resonate today. That a cultural competency approach in healthcare assumes that culture can be reduced to a technical skill for which clinicians can be trained to develop expertise. Culture is made synonymous with ethnicity, nationality, and language. It assumes that cultures are homogeneous and static, not making room for intersectionality or multiple identities and heterogeneity in communities. And it usually focuses on the other, the client, the patient, the other, rather than the self, which is a point I'll be getting back to in a second. Back in 1998, Kleinman actually came up with an alternative to the traits list approach. This was the very radical idea of just asking people what they thought was going on with them. Hey, what do you call this problem? What do you believe is the cause? What course do you expect it to take, etc.? Those of you who might be familiar with Anne Fadiman's book, The Spirit Catches You, You Fall Down, will remember that in that book, book now already from the 90s, that Kleinman's explanatory model was integrated into it. Unfortunately, Kleinman's explanatory model, unless we expect our storytellers, our clients, our patients, to be not just responsible for telling their personal story, but also the entire historical and socio-political story that is the context of their individual story, it has some limitations. Because, as my colleagues, and several of us share colleagues here, Metzel and Hansen, Jonathan Metzel and Helena Hansen, suggest in their work on structural competency, it is very important for a story receiver, a story listener, to always listen to the individual story in its structural context, right? No individual story can exist outside of structural context. But to gain that structural context, we cannot rely on or burden or expect the storyteller to always provide us that context. That is our homework to do, right? Metzel and Hansen in their work suggest people's morbidity and mortality is as connected to their zip code as their genetic code. They define structural competency as the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or diseases, depression, hypertension, what have you, represent downstream consequences of upstream decisions, right? So we can't just simply treat the downstream consequences. We have to look at upstream decisions like zoning laws, right? Redlining, rural infrastructures, medicalization, even the very definition, as we heard earlier, drapetomania, right? Of what counts as illness and what counts as health, right? So that is structural competency. So one more framework for you. Remember I said I was going to go back to that attitudes of the story listener. In a I think 2008-ish, in the early 2000s, I coined this kind of phrase, narrative humility. I was building on the work of Tervalon and Murray Garcia, who wrote about cultural humility, a practice dedicating to not just learning about them, but an inward looking and self-reflection about us. It's an attitude that examines clinician biases, frames of listings, expectations, and gaps in knowledge. The reason I termed it narrative humility and not, simply cultural humility is that I didn't want it to seem like it was something, a hat we put on when other people walked into our door, whatever that means to us, right? To acknowledge the fact that somebody seemingly with every age, identity, linguistic, gender, cultural marker as I would still be walking through my door with aspects of their story that was unknowable to me, that would remain opaque to me. There are elements of the unknowable in any patient or client story. Narrative humility, therefore, is humility to that which we do not know, but to which we are responsible. And as one of my students, our students are always our best teachers. One day when I was talking about narrative humility, a student of mine said, "Oh, I understand what that is, Dr. Descoupte." And this was a student who themselves was in medical training and had actually a neurological condition. She said, "I understand what it is. It's that we should all try to understand, realize that we'll never understand, but try anyway." And so that is narrative humility. And so as I'm kind of coming to the end of my very medicine-oriented part of this talk, I think what I'm suggesting from my position in narrative medicine is that as listeners, we must take a combination of approaches. We learn about belief systems while making room for ethnographic models. We think and learn and invest in learning about histories of oppression, sociopolitical barriers, structures, and power, while examining our own biases, frames of listing, and expectations. And the last, I think, framing I'll say is those are all intersubjective, meaning I'm centering here the individual story listener and the individual storyteller. I also, want to make sure that we acknowledge, at least for me, I'm coming from medicine, so I'll speak about the responsibilities of my profession as a whole, right? So not just we as individual physicians, in my case, but medicine as an institutional whole. And so in the last number of years, since the 2020 I've been writing about abolition medicine, which is medicine's responsibilities to broader abolition movements around prison, around policing. And particularly in 2020, when we saw the dovetailing of COVID and that iteration of Black Lives Matter movements, it became very clear to many of us the way that health and state violence was intertwined. There became a lot of talk around public health responses to public safety, right? Sending out mental health teams to folks in crisis rather than police with guns. But what is medicine's responsibility to constructing a public health response to public safety? For me, it went back to Metzl and Hansen. We couldn't treat downstream consequences of state violence, gunshot wounds, what have you, injured people, traumatized communities, without doing something about the upstream causes of that state violence. That was also a part of our responsibility. And so at the same time, I thought it was important for medicine, or I continue to think it's important for medicine to recognize and disentangle its own carceral logics, the construction of race as a somehow biologically meaningful category, which it's not, and yet we still rely on kind of race-based medical framings, diagnoses, treatment. We can see a direct line from that historical diagnosis of drapetomania all the way to the way that we understand lung capacity, right? And the way that even certain instruments that measure lung capacity have a race filter, right? You adjust for race on the incentives barometer, or earlier versions of the incentives barometer. So race is a meaningful category. Medicine is also responsible for the pseudoscience of eugenics, the idea that we could breed better human beings by encouraging reproduction among some, discouraging reproduction, and or just getting rid of others. Medicine has deep histories of experimentation. We can think about J. Marion Sims experimenting on enslaved women to develop the pelvic speculum. We can think about mental health institutionalization, biometric surveillance, and more. But for those of you who want to talk more about abolition medicine later, I will just suggest that it's, I think, a nascent field that owes much to the work of abolitionist scholars and activists like Mariam Kaba, Angela Davis, and Ruth Wilson Gilmore, who says abolition is not absence, it is presence. It is building the future from the present in all the ways that we can. So really, this has been the majority, this and kind of thinking about opacity and abolition has been the majority of the work that I've been currently doing. Okay, herein is the part of my talk at 15 minutes, where I am switching from that very medicine-centric question of what are the frames of listening we use to listen across power in medicine, to the question of global health. Okay, how do these understandings help us listen to population stories in the global health context? I'm going to share with you a photograph that many of you may be familiar with. It's a troubling photograph of suffering. It's from 1993. It's the Pulitzer Prize winning photograph by Kevin Carter. And what I'm going to do is actually maybe just from the people in the room, it might be harder for those on Zoom. I'm going to ask you to look at this photograph and in a sense, listen to the story it's telling and ask a question. So what, maybe I'll just take one or two questions. What's a question that occurs to you when you see this particular story, this photographic story, this visual story? Anyone have a question?
The question that always came to mind when I saw this photo was, why isn't it used for anything?
Why isn't anyone doing anything, right? And that's the question that often comes to mind when we see this photograph, which is, you know, quite well known. What it goes to is then, what are the responsibilities of listeners? In this context, viewers, right? What are the responsibilities of story receivers? Kevin Carter apparently writes about waiting behind a bush for the vulture to open its wings so he could get that photograph. He did not. This photograph was taken in 1993 in Sudan during a famine. Just to give a little bit further context, the photograph often becomes tangled with the photographer's own personal history. He did take his own life after winning the Pulitzer Prize. This image often becomes entangled with that discourse around the weight of witnessing. But just for our purposes today, I'll really ask us just to focus on the text of the photograph. Any other questions that occur to folks? Please. What happened? What happened next, right? We see there's a tightening of frame literally with a photograph that exists in both space and time, right? So what happens next? What happens next in this context is the image suggests that the child has fallen down, and the suffering is very real, but it's a little bit of a false image because apparently, again, from what I've read, the child is coming from a feeding center, not going to a feeding center. And that center is actually just a couple yards out of the frame. So both by time and space, we're given an artificial, story here, or a very particular story. I won't say artificial, a very particular kind of a story. Maybe one more question. Any other questions that occur to folks seeing this? Yes.
Horrible as I didn't think of any such. I automatically put my assumptions on what's happening.
Ah, that's super interesting.
It's painful, like this
Right.
horrible, like all of these instead of really questioning what's going on.
Yeah. Yep. So there are some kind of subtextual stories that already culturally exist that we pull up to frame our understanding of a story like this. I'll just give you a couple more for matters of time. People will sometimes ask, where is this child's parents? Where are his parents? Who is this child? So the child's face is down. We are literally meant to look upon someone who cannot look back at us, who cannot even implicate us in our looking. Right? So there is a certain voyeuristic, vulture-like, dare I say, quality in our own looking. Of course, the agentic character in this image is the vulture, not the child. So we have to ask ourselves also questions about our own kind of the spectacle of suffering and our own voyeurism in it. And the other question that often my students will ask when I show them this image is not just where are the other humans, but where's the other human-made things, right? This is a very naturalized environment. There's maybe some structures back there, I'm not sure, but no buildings, no tires, no, I don't know, cars, plastic bags, anything. And images like that tend to naturalize suffering, right? That there are brown and black children who are suffering in other places, and this is, we're really talking about the Euro-American viewer, in other places, but that suffering is so natural. It is inevitable. It is very sad, but it is inevitable. Rather than a structural understanding of, yes, famines happen, but usually famines happen because food is prevented from getting to people who need it. Because there are people with guns. Well, where do they buy those? Who are preventing those food trucks from coming? Okay, who supplied them with those guns? Those are the structural conversations to be had in a global health context. A couple of quick frames. Again, I don't know why Arthur Kleinman in this talk came up so often, but Arthur and Joan Kleinman in their text, Social Suffering, give us the frame of indigenous absence, which is useful in both US and global contexts. Images of distant suffering women and children suggest there are communities incapable of or uninterested in caring for their own people, but these photographs justify, and you could even substitute out stories, right? These stories justify colonialist, paternalist attitudes and policies, suggesting that the individual in the photograph must be protected as well as represented by others. Something must be done, it must be done soon, but from outside the local setting. So images of isolated and suffering children in particular, often women and children. Zilla Eisenstein, a US-based feminist scholar, comes up with the term women and children altogether, women and children, are often invoked to actually justify imperialist incursion, right? That military incursion. At least we're doing something, says someone who's justifying photographs like this. At least we're doing something. At least we're raising awareness of distant suffering. Well, are we though? And for what ends? Are we raising awareness to activate people or not? Is it actually doing the opposite of what we think? Susan Sontag suggests that it's the opposite, that compassion is an unstable emotion. It needs to be translated into action or it withers. The question of what to do with feelings that have been aroused, the knowledge that has been communicated. If one feels there is nothing we can do, who is that we, and nothing they can do either, who are that they, one starts to get bored, cynical, apathetic. So unfortunately, in global health, the question then becomes, if certain stories are in fact entrenching us in inaction, right? Narratives of indigenous absence and spectacles of suffering. We always have to ask, as we heard so beautifully stated in the beginning of our day, always have to ask who speaks and who is spoken for. Linda Martin-Alcoff, the feminist philosopher, in her piece, The Problem of Speaking for Others, says the practice of privileged persons speaking for or on behalf of less privileged persons has resulted in many cases in increasing or reinforcing the oppression of the group being spoken for. And Alcoff does not let us off the hook, though. She does not say, therefore you say, oh, I'm in a privileged position, I can't do anything. Rather, she says, we must investigate, and this is a narrative turn, right? We must investigate how to speak with rather than speaking for, right? We're speaking about. A couple of other frameworks that I'm sure that folks here are very familiar with, but just to, speak into the room. We can think about my colleague, at Columbia, Gayatri Chakraborty-Spivak, very classic framing of white men saving brown women from brown men, going back to this idea of indigenous absence and vulnerable members of communities, that white men must sweep in certain communities and rescue brown women or children from the terrible behavior apparently of brown men. And then this kind of pseudo-feminist framing becomes justification for incursion, military incursion or other types of incursion. Not to say that gender violence does not exist, but rather that certain framings of that story serve other agendas, right? So we need to kind of think about that. Lila Abudugad, similarly, you know, when it's very often Muslim women who are framed in these ways, you know, very aptly asks, do Muslim women really need saving? And if so, can they save themselves, right? So I'm just going to get to the end here with a couple of other ideas. So if you remember me talking about the naturalization of suffering, and then you looked at this image, you might say to me, well, gee, this is not a natural setting. Neither is this child prevented from looking back at us. This was a 2014 article during kind of an Ebola crisis, an Ebola epidemic at that time. And I would say that no, this story that we are seeing here falls into the tradition of that Kevin Carter story. This is a story, unfortunately, that is old as time, right? The distant, vulnerable child, the distant, vulnerable women and children. This child, just like the first child, is not the subject of the story. We are meant to look upon this child with a certain attitude. She's, yes, looking back at us, but literally falling out of the frame of her own photograph. Yes, she's in a human-made environment, but it's a human-made environment, a hospital floor seemingly, that is not functioning as it should. There shouldn't be body fluids and children lying on hospital floors. And so when we listen to such narratives as global community members, what else are we hearing, right? What other secondary stories are coming through? And what I'm throwing out there is that narratives of indigenous absence and spectacles of suffering that actually inure us from action, and the taking away of agency. All of that is what else is happening here, yeah? Particularly when we see, yes, this is a fictional image, it's from a film called Outbreak, I think. But we see images like this all the time, right? So we see images of kind of the global North's, Euro-America's medicinal and scientific capability, right? Versus the global majority's opposite. And there was a very interesting, I love kind of teaching from both scholarly and publicly accessible texts. So there's a really interesting, very accessible essay written in Jezebel a number of years ago that I teach from all the time on public health and colonialism. And in it, the author looked at these particular two images. And the author says, pernicious undertones lurk in these parallel representations of Ebola, metaphors that encode histories of nationalism and narratives of disease, African illness represented as a suffering child, debased in its own disease-ridden waste. Like the continent, it is infantile, dirty, primitive. Yet when the same disease is grafted onto the bodies of Americans and Europeans, it morphs into a heroic narrative, one of bold doctors and priests strapped down, experimental serums, hazmat suits, the mastery of modern technology over contaminating foreign disease. These parallel representations work on a series of simple historic dualisms, black and white, good and evil, clean and unclean. And like the quick foray I took into opacity, I will just say that racist soap ads is another like rabbit hole scholarly interest of mine. So I often teach from racist soap ads, and so if you're ever interested, I'm your scholar. Hit me up. I have more of these than you can count in my computer. This is a racist pear soap ad in which literally a child of color becomes white by virtue of using the soap. And so we can see how the ways that narratives of disease are mapped onto narratives of colonialism and narratives of racism, yeah? The first step in erasing the white man's burden is through teaching the virtues of cleanliness. The people of India are very much in the condition of children. They must be made to clean by compunction until they arrive at that degree of moral education where dirt shall be hateful to them. This British report doesn't have an author, but very much in line with Winston Churchill's notion of Indians as a beastly race who reproduce like rabbits. Sierra Leone, the white man's grave due to illness and contagion. This I just included in my slides because I love this name. Filipinos described by another colonialist as promiscuous defecators, which is the name of my, new punk rock band. The promiscuous defecators. So all this to say, I think I'll just end it here for matters of time, and also to give us room to discuss. When we want to use some of these frameworks of narrative justice in medicine and apply them to the public health context, I think we have to think about the ways that colonialism replicates, but also is unique to the way that US racism plays out. And the kind of secondary stories and the secondary narratives that are always, as that comment from back there suggested, that are always already listening for us. We are already listening to a story that we've already heard before, right? And so that would be kind of what I leave you with. I'm going to describe just really quickly a film because I know that this particular gathering is sponsored by folks who have a specific interest in neuromuscular disorders and Duchenne's muscular dystrophy. So Darius Goes West is a US-based film documenting a road trip of a lifetime of a young 15-year-old boy named Darius from rural southern Georgia, who goes on a road trip. He's a wheelchair user. He has Duchenne's muscular dystrophy. He goes on a road trip out of his community all the way to the Grand Canyon. He's never seen the Grand Canyon or the ocean. And he gets taken on this road trip by a group of friends who end up being college-age, all-white young men. It's actually, it's a very compelling, lovely film. We're meant to feel, very, affectionate towards this group of young men who are traveling across the country. But narratives like this, like Darius Goes West, like many of the narratives that I've been sharing, still compel us to ask questions like who is speaking, who is listening, who is the protagonist. In this particular film, I haven't shown a clip and you haven't seen it. Darius is the supposed protagonist, but he is actually kind of a device who is used for the growth of the other characters in the film. So who's the active subject versus who's the object of pity or emotional transformation? What's the narrative context? This is US-based film. The narrative context is very much about the way that race works in the US. What's the desire of the teller? What's the desire of the listener? What are the consequences of telling versus not telling, hearing and not hearing? And what are the hidden narratives that are being upheld by the primary narrative? This, I think, is my list of the ways that narrative medicine in the medical context and in the public health context overlap, right? These are the questions that we ask in both when we're listening to individual stories and population stories, right? So I think for matters of time, 31. I will just end there and take any questions or discussion. Couple of minutes for discussion so we don't hold ourselves up. Okay. You're very kind.
So, your point on the right to opacity. I was very curious I don't know if you saw this Super Bowl commercial a couple of days ago.
The Ring camera?
Yeah.
I just taught with it this week.
Oh,
but please go on. Yes.
No, I was so curious. As someone who studies this, I was curious what you thought.
Do you want to just describe?
Oh, sure.
Maybe I will because I'm the one with the mic, right? They can't hear me. Yeah. So say what you're gonna say, and I'll repeat it.
Yeah. So there's this new Ring, the doorbell with a camera. It has this new feature that they're advertising as helpful. The way they advertise is it can help you find your dog. by basically combining the data of everyone's Ring doorbell and using AI to track from one doorbell to the next.
Oh, it is picking up on your voice.
Okay,
Oh,
okay.
yeah, I don't need to repeat it. Yeah.
So the way it was framed was like you could find where your dog is because you see the same dog go from this house to that house to that house. But the idea that everyone's data and everyone's cameras would be shared and then used for tracking, it came across as quite dystopian. And also did not seem like dogs might be the only thing, or even necessarily the easiest thing to track. So as someone who studies this, I'm curious what you made or what you think of that.
Yeah, all of that. I mean, I found the Tracy McMillan Cotton, who's a sociologist, says very wisely that the reason that we are being pushed by these AI companies, the techno oligarchs, if you will, to assume that the future is already settled and that AI is inevitable and it's here, is because the future is so deeply unsettled and that it's up to us to resist. And so part of that resisting is both the plagiarism, environmental degradation, global labor injustices of generative AIs, but also generative AI's partnership with state surveillance. And, Palantir just got kicked out of Switzerland because, because of concerns about its surveillance practices. And so I thought the Super Bowl was I haven't seen all the commercials that my students have now told me about. I just came in for the Bad Bunny.
Yeah.
Which I'm sure you can't blame me for. But now I'm catching up on all the commercials. It was such a cultural moment where so many of the commercials were promoting, the inevitable AI future, that again is not as inevitable. We have to believe it's inevitable in order that there not be a bubble burst in that economy, I believe. And these kind of surveillance technologies. And, if you're interested, there's a, wonderful theorist, Rachel Hall, who talks about, I think her article is called Of Ziploc Bags and Black Holes. And she talks about the aesthetics of transparency at US borders. And of course, the way that now US borders aren't, in theory, a border should be a line. Right? But this 100-mile in from any border means that the entirety of the US is a borderland. And we know that drone technology, surveillance technology, kind of disenfranchised, that's all practiced at the border before it's, farmed out to other spaces. But of course, now we're all in the border. And this particular ad, if you haven't seen it, is it's very dystopian. It suggests that every Ring camera in a neighborhood can be activated to scan faces. And in the commercial, it's about scanning a dog's face, but to me, it is not about dogs. It is a dog whistle. It is very clearly meant to be scanning human faces. And the normalization of that kind of discourse is very much why this, to me, is a big deal right now. As somebody who, whose entire bread and butter is about stories, I'm like, no stories. We're actually going to think about not telling as acts of resistance. So indeed. Sorry, that was a tangential answer. Shall I go?
Especially a pacifist resistance, it makes so much sense because I'm not the indigenous people's communities that I'm involved with, and a lot of historically, a lot of indigenous people never revealed. It makes a lot of sense. But I never thought of it as a capacity as resistance. I thought that's a great phrase to remember. That's what they were doing because they did. They had to.
But also just the frameworks of some. I have a colleague who's an Indigenous scholar, Audra Simpson, who a lot of her most recent book was about all the things that she's not telling. She's just not describing them, but saying that there are things that are meant for certain community members' ears only and not outsiders. And so maybe that was already a baked in, maybe it's wasn't resistance if it's a cultural practice that's so baked in. Yeah,
Well,
so
there's a film of this movie called The Eternal Song by this husband and wife team that went to film a documentary of many different indigenous healers. I can tell more about that later. But they had to establish a lot of trust before they were, indigenous healers were sort of felt that, okay, these people one can actually reveal some of our healing practices. So I know what you mean, that sometimes baked in, but also a lot of it was just they just very consciously delivered.
no, that's what I mean by
Well,
baked in. Like we know that certain knowledges aren't meant for everyone.
Right.
And so like
Especially
that's just
not
our
these
practice.
people.
Yeah, especially not these people. But you don't even have to, in a sense, like if that is your cultural practice, then you almost don't have to be confronted by the voyeurism of the story grabber to know that no, we don't like that's not something that everyone needs to know. Like I kind of love that as a practice. Should we wind up? Oh yes. Shall I?
I don't know that much about graduate medical education, but when I'm thinking about when I've observed a group of residents doing a differential diagnosis, or when I've kind of shadowed them around it, it seems like there are very few opportunities there to engage in any type of narrative medicine approach. Where have you been able to successfully insert this to our training?
Yeah, so luckily, we've been around for maybe 2001, our program started. At the beginning, it very much felt like training the youngest members of a community to go in and get like smashed by the older members of the community. It felt terrible. We've been around enough now that there are deans and medical educators who've come up with these frameworks of understanding. So I would say that almost every medical school in this country has some form of a narrative medicine program. How integrated it is a separate question. Is it an addendum? Is it an extra nice thing that you do at lunchtime? Or is it a rigorous kind of funded, made space for, area of work is a different question. But it used to be that we were nowhere. We were so marginalized that we were nowhere in medical education. Now I would say that we're everywhere. The next kind of battle is, are there people who are recognizing, it's like abolition medicine, like, are you recognizing that the structure itself has to be disentangled, right? It's a question of kind of pedagogy, right? Like a Paulo Freirean question, like how do you actually disentangle the power dynamics embedded in that educational system? You can't just add in this new thing as content. It actually changes the way we teach, I think. So yeah, but luckily, we've definitely seen some movement. So thank you so much.
Just a reminder that those of you out in Zoom land, if you have questions, please use the available Zoom facility for that. And those of you here, if you want to take advantage of our food, we'd love you to do so.
Right. It is my real pleasure to introduce Dr. Benjamin Saunders, who, first of all, was my mentor and incredible research director, an associate professor of psychology at LAU Brooklyn, who conducts research on the causes and consequences of social movement, and as well as resistance to racial and social policy preferences and racial attitudes. And he's going to be speaking to us about the role, about systemic and medical racism, the role of system justification in racial and social policy. So much.
Thank you very much, Rachel, for the introduction. Thank you for inviting me to contribute to today's distinguished panel on narrative justice in global healthcare policy. In my time, I'm going to discuss two projects that converge on the problem of racial disparities. First, I hope to offer policymakers a useful definition for systemic racism. Then I'll discuss systemic racism's relevance to racial disparities in medical outcomes and beyond, before outlining a second line of work on the role of system justifying ideologies in racial and social policy preferences. But in preparing for today's discussion and how to convey the nature and content of systemic racism, I was reminded of one of my favorite infomercials from the 1990s. In this 30-minute infomercial, the pitch person is selling a rotisserie chicken maker, and he repeats the phrase, "Set it and forget it," right? He just said it and forget it. Who remembers this? Does anyone remember this rotisserie chicken? You just set it and forget it, right? And in this infomercial, after saying this a couple of times, he doesn't even have to say it anymore, because then he just says to the audience, and you can just, and then they say, "Set it and forget it," right? Sorry, there's something.
Can't see your slides right now.
Oh, no. Oh, pardon me. I hope I messed something up. So just hold on to that moment while our AV, I will say, I wish that I would have included some material from this infomercial. I didn't think I had the time. But yeah, next up, David.
Did you end up buying the product?
Did I end up buying the product? Well, when this infomercial was released, I think I was like 15-ish. And so I wasn't particularly interested in a rotisserie chicken maker at the time. That being said, the advertisement certainly stuck with me. Okay. In any case, what I ultimately meant to say is that this notion of set it and forget it is essentially how racism works, particularly systemic racism. So systemic racism allows for the maintenance and reproduction of racist contexts, which in turn maintain racial disparities. The continued existence of these racial disparities, along with widespread racial inequality in nearly all of its forms, is taken for granted by a great many social scientists, as is its hierarchical nature. More than a decade ago now, sociologists could write that thousands of scholarly studies have documented the discrepancies that favor whites over blacks across every major subsystem in American society. Did it go off again?
No, continue.
Okay, sure. Relatively more advantages are conferred to white Americans, and relatively more disadvantages are unloaded on Black Americans and Americans of color, such that racial inequality is ubiquitous in residential patterns, that is where we live, education, work, housing and mortgage markets, credit and consumption markets, health services, discipline, incarceration, criminal justice service related services, to name a few. So the nature of racial inequality is so rife with hierarchy that Reskin further advanced that, let me make sure my slides are moving here. Hold on one moment. Just want to make sure I can get my slides to advance. There we go. All right. And let me see if that, excellent. All right, we're back on pace. Such that we can say that in virtually every realm for which evidence exists, from the bottom to the top of the socioeconomic hierarchy, whites remain better off on average than blacks. And recently, it was argued that the origins of the American racial hierarchy date back to the slave codes of colonial Virginia, which situated humans legally such that whites occupied a dominant position, Africans occupied the subordinate position, with other ethnic groups, including the indigenous, in between. Thus, though not every social scientist would agree that something like the schematic represented in Figure 1 exists, the research to date would suggest that a racialized hierarchical system of discrimination in the United States is not a fringe idea. Just bookmark that idea. Okay? That this idea that there's a racial system, it's not really a fringe thing. It's something that's been well documented by sociologists. There are tens of thousands of articles or thousands of articles on this very topic. All right. So let me just continue by trying to offer a definition for systemic racism, and one that I think we could ultimately quantify, which can lead to some rigorous examination. So one definition offers that systemic racism refers to the processes and outcomes of racial inequality and inequity in life opportunities and treatment. Systemic racism permeates a society's institutional structures. That is, their practices, their policies, their climate. It permeates social structures. It permeates individual mental structures. It permeates everyday interaction patterns. That is, systemic racism not only operates at multiple levels, it can emerge with or without animus or intention to harm, and with or without awareness of its existence. And I said that I was going to offer a way to quantify systemic racism. So one way to quantify it is by examining aggregate or regional level, that is county or core-based statistical areas, or state or nation level implicit bias scores. So that is not the individual level bias scores, right? But at the county, state, or nation level. And from this point of view, regional level IAT scores represent positive or negative mental associations cued spontaneously by social groups, or automatically evoke mental associations about social groups, or an ongoing set of associations based on inequalities and stereotypes in the environment. In examining these aggregate implicit attitudes as systemic racism, there's a model, the bias of crowds model, that advances that social contexts have their own distributions of implicit bias, and that these contexts often overlap. Importantly, this means that aggregating implicit bias scores across a given context can be used as an estimate of the implicit biases shared most widely within that context, even if the individuals in that context change over time. So, in speaking to the present moment, that is the increased surveillance, capture, detention, and deportation of immigrants through the Trump regime's expansion of ICE, Curdy and colleagues examined the relationship between county level aggregates of the white Asian versus American foreign stereotype IAT obtained using archival data from the Project Implicit educational website. And what they did is they examined anti-immigrant vote shares from 18 real-world ballot initiatives in 10 different states over a 28-year period between 1994 and 2022. In doing so, they found that county-level white American versus Asian foreign associations on the white Asian American foreign stereotype IAT predicted anti-immigrant vote shares in real-world ballot initiatives, or to put this another way, that the aggregate or county level anti-foreigner immigrant bias predicts real-world outcomes. In continuing and returning to the set it and forget it slogan, that I borrowed to describe how systemic racism functions. Counties and states more dependent on slavery in 1860 have greater implicit bias scores among whites now, suggesting that racial stereotypes and attitudes are more likely to be spontaneously activated in those areas that were more dependent on slavery in 1860. So you can set it and forget it, okay? So the individual in this case doesn't need to be biased to reproduce racism in context with these pro-white, anti-Black associations. This work has established that white Americans' county level biases on the race IAT corresponds with the disproportionate stopping of Black versus white drivers. That is, using data from more than 130 traffic stops with various regional aggregates of racial prejudice and stereotypes, Stelter and colleagues found that racial disparities in police traffic stops were related to white Americans' local levels of racial bias. So, for example, you can see how the disproportionate stopping of Black drivers, that is what's listed here in panel A, overlaps with the areas higher in whites' racial bias, which you see in panel B. But white Americans' aggregate level pro-white, anti-Black associations are also related to life and death outcomes, whether in our daily lives or in the hospital. White Americans' aggregate level implicit associations predict the regional use of lethal force against Black Americans. In other words, racially biased contexts, not just the individuals within them, contribute to the disproportionate use of lethal force against Black Americans. Now, having established aggregate level implicit bias scores as a proxy for systemic racism, I'll now focus directly on systemic racism or regional level bias as it relates to health as well as medicine. This work suggests that Black Americans' aggregate level associations are equally, if not more consequential than whites associations, but for different reasons. Because Black Americans' county level implicit biases towards whites predict their dying from circulatory related causes. That the Black-white racial gap in low birth weight is 14% larger in counties with relatively higher versus lower implicit racial bias further buttresses the significance of aggregate implicit attitudes. That is, we see that racial disparity in low birth weights widens as county level bias increases at both the implicit and the explicit level, and that most of the widening results from Black mothers experiencing worse outcomes, though it's also partially the result of white mothers having fewer adverse birth outcomes as county level prejudice increases, right? So what we're seeing here is that this slope, right, for Black mothers is increasing, right? The slope for white mothers, as prejudice increases at the regional level, right, it's suggested for white mothers, right, we're seeing decreases in those things, right, or potentially that there are just no changes. So bringing data to bear directly on the topic of systemic racism in medicine, recent research suggests that white Americans, stronger pro-white, county-level implicit racial bias predicts poor clinical quality hospital care for both Black and white patients age 65 and older with Medicare, and predicted lower influenza immunization rates for Black but not white patients. Now, when I'm speaking about hospital care outcomes, I mean outcomes like adult BMI or body mass index assessment, diabetes care management, such as eye exams and controlling blood sugar. So as white residents' county level implicit bias increases, these care outcomes worsen for both Black and white patients. In general, the work on regional implicit bias and health outcomes suggests that aggregate biases harm both Black and white Americans, but they are especially harmful for Black Americans. Black and white patients who live in areas with higher county level implicit and explicit regional bias tend to report higher incidences of chronic health problems like cancer or stroke or asthma or diabetes and heart failure. So what you see in figures 1 through 3 is that as whites county level pro-white bias increases, so too does the prevalence of heart failure, cancer, and strokes for Black but not white patients. So you might be wondering at this stage, right? This is kind of grim, right? And I said that some of these associations that we're combating have been set, right? Long before the Civil War even started. So what can I offer to combat systemic racism? Well, I hope to offer a few different things. One, I'm going to present some bad news first, right? And that's that research suggests that it's not particularly likely that the outcomes that I just described could be meaningfully addressed using interventions seeking to change participants' performance on measures of implicit associations like the IAT. Rather, what research suggests is that social scientists should develop interventions that seek to change the defaults within contexts, such as organizational settings, for example, by requiring that employees opt out of consideration for promotions rather than the default be to opt in, or by using admissions dashboards to contextualize qualifications in admitting prospective students, or by developing software that could remove automatically those features that would bias judgments in a judicial file. But in a politically polarizing time, such as now, for example, in Minneapolis, collective action mobilizing against the expansion of ICE agents is, like many other recent examples of civil unrest, met with aggressive protest policing. It's met with the proliferation of protest-related sanctions, the bringing of augmented or higher level charges against protesters, the federalization of responses to local public unrest, and other measures that jeopardize even peaceful protests and acts of civil disobedience. So what I want to do is introduce another perspective from my good colleague and collaborator, Jeremy Sawyer, on the role of social movements in attitude change. First, in employing this perspective, we acknowledge that many biases are decreasing, right? So here's a little bit of good news, right? Social scientists, policymakers, and lay people alike may find some optimism in the 98% and the 26% decreases in explicit and implicit biases, respectively, since 2007, right? So there's some good news for you. Though these biases nonetheless persist, as do aggregate trends in anti-Black, anti-gay, anti-disability biases. But we contend that these reductions in bias result in large part from the contextual impact of social movements. Though the malleability of aggregate implicit attitudes is well documented, there is not yet agreement on what factors account for reductions in bias. In employing social movement theory, we advance the idea that societal level implicit and explicit attitude change coincides with contentious collective action exerted by people who often lack institutional power and who are often in conflict with political and institutional elites. The array of outcomes brought on by contentious collective action varies from actions that compel elites to reform all the way to social and political and economic disruptions that may spark revolution. In emphasizing contentious collective action as a catalyst for bias reduction, we further ground our theorizing in social movements as parsimonious explanations for implicit and explicit attitude change. In doing so, we're focusing our research on the outcomes of collective action rather than its predictors. Or to put this another way, rather than examining the factors that motivate or demotivate collective action, the present research examines the degree to which engagement in collective action changes people. But just as a preview, I do also study the factors that motivate or demotivate collective action, and we're going to talk about that in just a minute too. But one working definition of social movements suggests that they possess four key characteristics. First, since social movements and their leaders often lack funding, organization, and access to municipal resources that interest groups and parties control, they rely on disruptive direct actions, including protests, sit-ins, boycotts, blocking traffic, strikes, and the like. In other words, social movements are contentious by nature. Second, social movements bind people through the realization of shared interests and values that compel them to endure personal risks to act collectively. Third, since social movements bind their participants, these activists recognize their shared interests consciously and depend upon one another for support, for protection, and for the furtherment of empowerment and well-being. And last, social movements involve engagement in sustained political confrontation over time. So, taken together, social movement theory suggests that contentious collective action shifts norms, shifts public norms, moral understandings, and political considerations, and history is actually replete with examples. Right? I'll start with perhaps a more negative one, and that is Donald Trump's Making America Great Again election campaign. Though not a formal social movement, it motivated regressive collective action from the political right via the emergence of the alt-right, fake news, and the conspiracy that white Americans are being replaced. Thus, though the acceptability of prejudice against stigmatized groups increased following Trump's election, our argument would be that the observed increase, right, in the acceptability of prejudice towards oppressed groups likely resulted from the sustained organization of the MAGA movement than the election per se. Witnessing the killing of unarmed Black Americans motivated progressive collective action from the political left in the Black Lives Matter protest movement, and supporting research suggests that its emergence coincided with reductions in aggregate pro-white implicit racial bias, and a similar trend emerged during the BLM protest movement's resurgence in 2020, and that there were rapid decreases in implicit racial bias following the onset of the protests. Though not necessarily social movements themselves, participation in labor unions could lead to contentious collective action like strikes, and supporting research suggests that both current and past participation in labor unions predicts decreases in racial resentment among white workers, revealing yet another important implication of social movement theory, and that is that the effects of movements like labor struggles may spill over to seemingly unrelated areas like racial attitudes. So in one project with Jeremy Sawyer and Yama Chirko, we focus specifically on the psychological impacts of strikes in the education sector. Strikes represent, again, a particularly powerful form of collective action. Unlike strike protest, or rather, unlike symbolic protest, they interrupt the everyday functioning of workplaces and public institutions, compelling policymakers, communities, and the public to confront the conditions that led the workers to withhold their labor. Teacher strikes, in particular, have been a defining feature of American labor movement since the 1920s. And what is unique about relatively more recent teacher strikes compared to other labor movements is their intersectional nature, their intersectional solidarity. That is, historically, workers across ethnic and racial lines have joined forces to demand change. Moreover, the effects of teacher strikes extend far beyond the educators themselves, cascading across students, across families, and entire communities. So, for example, teacher strikes from 2007 to 2023 were found to increase teacher pay by 8%, decrease teacher ratios, and garner increased state revenues for education over a period of years after the strike. Yet the question remains, what are the psychological consequences of these actions? While we know that strikes can improve material conditions, we understand far less about how and whether they spur on widespread psychological changes, including in local, regional, and or national implicit and explicit social attitudes and public consciousness as reflected in internet search patterns. Teacher strikes offer a uniquely powerful case for studying attitudinal change. They are highly visible. They are deeply moralized and often framed as struggles not only for teachers' wages, but for racial justice, for school funding equity, and for community well-being. That is, in terms of bargaining for the common good. Moreover, teacher strikes render children themselves as a central, if often implicit, battleground. Unlike labor actions that disrupt the production of goods, teacher strikes intervene directly in the social reproduction of the future. For example, strikes are frequently framed as costing children a day of learning or imposing childcare benefits on families, all the while exposing the fact that children's well-being is inseparable from the conditions under which adults labor and care for them. This expansive framing makes teacher strikes particularly likely to influence psychological biases. So you may be wondering what mechanisms account for why teacher strikes in particular, conducted on a small subset of the population, might shift public consciousness and implicit and explicit biases. Drawing on Sawyer and Gompa's framework, teacher strikes can shape implicit and explicit attitudes through several pathways. At the aggregate level, strikes are catalysts for structural reforms and shift media narratives towards highlighting systemic inequities. At both aggregate and individual levels, they expand intergroup contact by bringing teachers and parents and students and community organizations into collaboration, fostering solidarity, and reducing prejudice. At the individual level, teacher strikes heighten the visibility of exploitation, prompting perspective taking and empathy, and reducing intergroup anxiety. They also promote social recategorization by framing diverse groups such as teachers, parents, and children as part of a shared cause, thereby broadening the boundaries of us. Finally, strikes can reshape social identities and strengthen collective efficacy by demonstrating the legitimacy and power of coordinated action. Together, these mechanisms illustrate how teacher strikes, despite involving a relatively small segment of the workforce, can produce diffuse psychological effects and shifts in public attitudes, and few studies have empirically tested these relations. So we're in the process of examining them now. So I want to recommend, along with the previous recommendations that I had for some changes, that policymakers view collective action in civil unrest with more openness. All right, so I said I was going to talk about a couple of things, and I just finished talking about that first thing, which is systemic racism, right? And some of the things that we can do about it, right? But I'm also going to talk about racial hierarchy, so this is time for the pivot, okay? And remember that I said just a moment ago that though I am interested in how social movements might change people, that I am also interested in the factors that motivate and or demotivate collective action. And so we're going to talk, or you're going to hear me talk a little bit about that work in the next few slides. And if you remember, I said just a moment ago that we were going to come back to this figure, right? And to this simple idea, right? That that sociologists, right, would say that thousands of scholarly studies have documented disparities that favor whites over blacks across every major subcategory. And once again, this idea that there is a hierarchical racist system in the United States. Again, it's not a fringe idea, right? And I said we were going to bookmark that point. So where exactly am I going with this? Okay. Well, in using shorthand to describe Black Americans' doubts about the fairness of U.S. institutions, in other words, that they view those institutions with suspicion, a June 2024 report from Pew labeled Black Americans as racial conspiracy theorists for beliefs that disadvantages were anything other than general error. So let's pause and reflect on this, okay? There are roughly 48 million Black people in the United States, okay? And they are asked, right, or a representative sample of them are asked to complete a survey about American institutions, right? And when they view those institutions with suspicion, with the stroke of a key, right, we would say maybe a good half, right, 24, 25, maybe 30 million of them are conspiracy theorists. Whoops. I don't think I did that.
Yeah.
Right.
Well, it wasn't.
Right. Who for the UN works for the man.
No. No conspiracy whatsoever.
Did I step on something?
No, it's up and working.
Oh, it is a.
It's just not.
Oh, it's not here. So my people online, I think you can see my slides. So I'll just ask you to marinate on that for a minute. Maybe. I think the people in person. I think maybe the projector just went to sleep.
Yeah, maybe, but I don't have the
Is
remote.
there a remote?
No, it's in the internal.
I see. Okay. In any case, as we're taking this this tech break, I'll say that in Rachel's introduction, or in part of her talk, she talked about, I think, what she called protest psychosis, right? Protest psychosis, right? Dr. Dasgupta discussed drapetomania, right? This idea that to want to abandon, right, to want to save oneself from oppression in something like slavery is somehow psychologically wrong, right? And once again, what we're seeing in this dynamic, right, is that, you know, Black Americans, for, you know, expressing some suspicion over American institutions that have long harmed Black Americans, right, that we're seeing as conspiracy theorists, right? So maybe we'll just hold there. I'll let a few people in the audience get some snacks, and we'll be right back.
Tell me, that study that you had out that found Black Americans to be conspiracy theorists.
Yours. This is fine.
Yes.
So there was a question from the audience about who was responsible for that title, right? So the report is by Pew, right? You know, that does like public opinion research, right? If I remember correctly, I think, you know, sadly, I think the lead author on that particular project, or the person responsible for it, not necessarily that decision, but the lead person, wonderful, was an African-American woman, right? And that's going to actually lead to my second point. All right. So we are, yep, we are back. We're back. Wonderful. So what I would say is that ultimately, right, we have this racial conspiracy theories about the U.S., this Pew report, right? So someone from the audience asked, like, who wrote the report? Kiana Cox, right? Now I don't say that to put Kiana on blast, right? But I'll continue to the next topic with this. Ultimately, Pew did revise their title so that it was changed to most Black Americans believe U.S. institutions were designed to hold Black people back. But what I offer is that their title selection is a reproduction of racism, however small. And I point that out not to judge Pew or Kiana Cox, but rather to caution that these glitches in the system may involve well-intentioned actors with deep commitments to social justice. And one theory from the psychological, rather than the sociological side of social psychology, seeks to explain the psychological and socio-political antecedents and consequences of legitimizing versus criticizing societal status quo. But before covering that ground, I need to remain on the sociological side for just a moment. Because the sociological finding that race is a discriminatory system rather than a set of independent racialized subsystems implies that the reciprocal feedback across subsystems produces uber or emergent discrimination. To put that another way, the sine qua non feature of systems is reciprocal feedback or links with each subsystem, such that, for example, the healthcare system affects credit markets and vice versa. One prevalent sociological perspective is that these mutually reinforcing subsystems produce, again, uber discrimination, which is situated in the center of the racial hierarchy figure that I shared earlier and that you can still see on this slide, with reciprocal links between them. That is, these blue arrows showing how emergent discrimination occurs. Now, definitionally, uber discrimination distorts how we see others, the attributions we make about them, and our predictions of their performance. It misinforms our understanding of events and our inferences about causes and consequences. And this definition shares considerable overlap with the psychological phenomenon of interest to system justification theorists with respect to the psychology of racism. We're interested in how variability in evaluations of the status quo influence how people see others, that is stereotyping, as well as the attributions made about people and the predictions about their performance, their understanding of events, and their inferences about cause and effect. In short, system justification theorists are interested in how the system affects one's psyche. The theory, system justification theory, examines the degree to which ideology and dispositional preferences for the status quo affect why people do and do not rebel against the systems that disadvantage themselves and others. In referring to ideology, I mean the socially shared system of beliefs about the proper order of society and how that order can be achieved. And supporting research suggests that it accounts for considerable variability in voting behavior and has downstream consequences on social policy and intergroup behavior. We argue, moreover, that political ideologies are just one form of system justifying ideologies, and we employ system justification theory in examining support for exclusionary racial policies in opposition to general racial progress. According to system justification theory, people are motivated oftentimes to defend, to bolster, and to justify the societal status quo, that is, those systems on which we depend. And importantly, I've developed a new measure that is racial system justification, precisely because research on the moment, that is continued systemic racism, as well as movements, things like the Black Lives Matter protest movement, called for it. In the same way that research on the dispositional preferences for the general economic and gender status quo necessitated the development of the economic, and of the gender-specific system justification scales, we developed a new measure of racial system justification with the goal of added incremental variability or validity in the content of American race relations. But with respect to our specific measure, as an aside, I should qualify that the word new and say that the measure is newish, because there is some existing work on racial system justification. In 2020, Rudman and Saad found that it mediated the relationship between social Darwinism and support for Black Lives Matter. Much of the present data was collected roughly concurrently with Rudman and Saad's data, and I'll discuss how our measure departs from theirs in just a moment. But in undergraduate, as well as online and in nationally representative samples, we've examined the role of general and racial system justification along with political ideology in motivating support for exclusionary racial policies, so things like border fortification, right, as well as demotivating support for general racial progress, so things like BLM, reparations, and support for compensatory affirmative action. So taking a quick bird's eye view of our data, I'll quickly highlight an undergraduate sample before discussing a non-student and a nationally representative sample. And as you see, the undergraduate sample was predominantly a female, and it wasn't very representative. It was also primarily non-white. The Amazon MTurk sample was less diverse racially, but split evenly in terms of gender. And then our third study involved data collected from the Psychology of Political Behavior Studies. It's a large nationally representative sample. All right. Right. So just a little bit about my methodological approach. all right, across a number of different studies, right, I'm examining the same predictor variables. Those predictors are demographics, primarily age, education, gender, and race, along with symbolic ideology, which I'll talk about in just a moment, as well as general and racial system justification. Symbolic ideology is an aggregate of participants' responses to 3 items that you'll see on a slide in just a moment, okay? And then the general system justification scale assesses the dispositional tendency to defend the societal status quo, and participants answer those items on scale responses ranging from 1 strongly disagree to 9 strongly agree. Of special note is the measure of racial system justification that I described earlier. Remember that it departs from an existing measure in that our measure includes 16 items rather than 8. We adopted items from the general and economic system justification measures, whereas Rudman and Saad adopted items from just the gender-specific system justification scale. And the present analyses will focus on the full scale, though the dimensionality of that scale is under investigation, and the aim is to have a psychometric paper under review by the end of the spring. Right now, what I also want to say is when I say the dimensionality of that measure, right? If we're not, if we don't have our heads squarely in research, what I mean is that there might just be one dimension or one overall factor. There could be a few different factors here. Yeah. All right. So our outcome variables were taken from polls and were often single item measures, which are quite common in political psychology. And the political psychology of behavior study used a mixture of feeling thermometers and psychological scales. And so I'll discuss these specific items, or rather you'll see them in the case of the single item measures as I discuss the results. All right, finally, in terms of the data analytic plan, across these 3 studies, exclusionary racial policies and attitudes towards racial progress were statistically regressed on demographic variables, ideology, and general and racial system justification. Now, for these analyses, I ran hierarchical regressions with 3 blocks. The first block includes the demographic variables. The second block includes symbolic ideology. The final block includes general and racial system justification. So I list the exclusionary racial policies in the center column here, and the attitudes towards racial progress examined across each study, right, in the rightmost column. All right, just a little bit more kind of in the weeds nerdy stuff. And then we'll get into the results. I do want to offer a quick note on measurement, especially with respect to our primary predictor variables, that is symbolic ideology and system justification, right? And so I've already shown you some examples of the racial system justification scale, which is measured on a 1 to 9 point scale. And then you also see the items that are aggregated to measure symbolic ideology, right? It's just liberalism, conservatism, okay? All right, so we are now ready to jump into some results. These are results from our first study. This is data that was collected in the undergraduate participant pool at Long Island University in downtown Brooklyn in the academic year of 2022 to 2023. Again, this sample was predominantly female and predominantly of color. Now, with support for compensatory affirmative action, right, we have items like Black should receive racial entitlements such as affirmative action and other forms of compensation due to the past injustices of white America, as well as, a reverse scored item. Blacks have to learn that they are entitled to no special consideration such as that provided by affirmative action programs. It must be taken strictly on merit. Notice that the demographic items here accounted for very little variability in support for compensatory affirmative action. So let me kind of just break this down, okay? What you see here is a perpendicular line. This is what you call a dot whisker plot, right? And the horizontal lines over the point estimate there is a confidence interval, right? So if either that blue dot or the perpendicular line, this horizontal line, touch this perpendicular line, we would say that that effect is non-significant, not statistically significant, right? If it is away from the line in either direction, right, we have a statistically significant variable, right? And so what we see here is that age, education, gender, and race seemingly are not related to student support for compensatory affirmative action, but what is racial system justification and ideology. Importantly, these things negatively predict support for compensatory affirmative action. All right, so I'm gonna go over a few more results. Now we're looking at intolerance of Arab Americans, and in answering items like Arab Americans should have their phones tapped by our government, and Arab American citizens should be allowed to hold public rallies. That second one being the first scored. What we see again is that education negatively and age positively predicted intolerance of Arab Americans, but that demographics contributed very little variability. Okay, so what we see here, right, is remember that there are 3 blocks in this multiple regression. Okay, and what we're seeing is that as we go from blocks 2 to 3, that is the block that has racial system justification in it, right? The model remains significant. Okay, so reviewing these results again, we see age is it related? Maybe not so much. Education a little bit. Okay, what we see here is that racial system justification positively predicts intolerance of Arab Americans. And keep in mind that this is primarily a sample of color, right? From downtown Brooklyn. All right. Recall that the variables and the data analytic approach were fairly consistent across all samples. So we used psychological scales in the first study to examine exclusionary racial policies and attitudes towards racial progress. In the second study, we focus on a few single item measures in a larger non-student sample before finally reviewing some feeling thermometers and additional psychological scales in our last study. All right. So remember that data from study 2 were collected from Amazon MTurk in September of 2018. The sample was evenly split in terms of gender, primarily white and college age. And with respect to BLM, right, you see that this was a single item measure. Do you oppose or support the Black Lives Matters protest movement? And the results suggest that being white predicted opposition to BLM, that demographics accounted for hardly any variability in support for BLM. The magnitude of symbolic ideologies R squared, which tells us how much variability all these variables are soaking up, it dwarfs the demographics by comparison. Symbolic ideology predicted opposition to Black Lives Matters. And though the effect of racial system justification is stronger in the third block, note that the coefficients for general and racial system justification are divergent in their direction, with racial system justification and racial system justification negatively, right? But general system justification positively, though it's just on that other side, predicting support for Black Lives Matter. Moving on to the border fortification, or building a wall along the Mexican border. In examining border fortification, demographics are once again accounting for very little variability. The magnitude of symbolic ideologies R squared exceeds the demographics considerably. Symbolic ideology and racial system justification positively predicted support for building a wall along Mexico in our third block, though general system justification is non-significant. Okay, so let me try to interpret this, right? In terms of what matters here, right? Does political ideology have something to do, right, with support versus opposition for building a wall along the border with Mexico? Absolutely, right? Conservatism is associated with support for building that wall, right? As are evaluations of the racial status quo, right? Those people that are fine with the racial status quo are also very much fine with building a wall along the Mexican border, which I think makes sense, right? Those that are critical of the racial status quo, right, would probably be less supportive. All right, so let me just continue. With respect to family separation, all right, we see the same pattern in examining the discouragement of border crossing by separating families at the border. Demographics accounted for very little variability. Symbolic ideology contributed considerably more variability in that second block, though the effect of racial system justification is stronger in the third. Symbolic ideology remained a strong predictor, though general system justification was non-significant. Importantly, we're seeing an interesting trend here, right? Let me just kind of stay here for a second, right? So ideology apparently matters, right? When we're talking about exclusionary racial policies, right? Evaluations of the general status quo seem to be irrelevant, right, to that evaluation, right? But evaluations of the racial status quo seem to be very important. Okay, so as we transition to our discussion of the nationally representative sample, this is my last project, I want to note the emergent pattern whereby system justification seemingly manifests itself in distinctive societal domains. In other words, even after statistically controlling for symbolic ideology, when racial issues are under consideration, appraisals of the racial status quo may offer considerable utility to social and political psychology. All right, data from this third study were obtained in August of 2020 via the Psychology of Political Behavior Studies. This, again, is the data that is nationally representative. And support for BLM was measured with a feeling thermometer, where 0 would represent extremely negative, and 100 would represent extremely positive. And in examining this feeling thermometer in a nationally representative sample, we do see that being white, as well as being relatively older, predicted negativity towards the BLM protest movement, along with symbolic ideology and racial system justification. We also see, however, that general system justification predicted positivity towards BLM. Demographics contributed more variability to support for BLM than in our non-representative samples, but the R squared here remains drastically smaller than the other blocks, right? And so what that means is demographics are predicting something, right? Whether someone is white, whether someone is relatively older versus younger, that matters in terms of their evaluation of BLM, right? But what matters most, right, is racial system justification, at least within this context. All right, just a little bit more, and I'll be wrapping up. Support for reparations. In examining support for reparations with items like the United States government, as a way to make up for the harm caused by slavery, should make cash payments to Black Americans who are descendants of slaves, or there is no point in the U.S. government apologizing to Black Americans for slavery in this country, the second one being reverse scored. We note the same emergent pattern. Demographics play a more important role in representative data, but adding symbolic ideology to the model added substantial explanatory power. And after statistically controlling for symbolic ideology, which remained statistically significant and negative, general and racial system justification explained unique variability in support for reparations. But general system justification predicts support, and racial system justification negatively predicts its support, right? So if we think that the system is fair, all right, if we generally think that tends to be associated with support, right? For representation, for reparations, right? But if we think the racial status quo was fair, right, that seems to be associated with opposition to reparations. Okay, so I'll say that again. Demographics played a more prominent role in this data, but again, adding symbolic ideology and then general and racial system justification to the model substantially increases how much variability this model accounts for. All right. One last data picture, and we are done with respect to examining border fortification within a nationally representative sample, right? We see the same pattern, okay? Education predicted opposition, and being white predicted favorability towards a border wall. We would also note that the R squared for the second block is nearly 7 times the R squared for the first block, right? So demographics are not accounting for all that much variability in border wall support, right? What is counting for variability, right? Ideology along with general and racial system justification. All right. So you might be wondering, where does this leave us? If you weren't already, I hope you're now relatively more open to the suggestion that ideology and evaluations of the general as well as the racial status quo matter in reflecting on American politics and so-called race relations. I also hope you're relatively underwhelmed with the role of demographics in socio-political attitudes. When social identity is relevant, but ideology matters. We first reported preliminary support for a racial system justification measure with incremental validity. I also examined general and racial system justification and how they converge and diverge as predictors. And in doing so, this research further supports evidence that system justification comprises multiple meaningful dimensions. We also found that system justifying ideologies, that is beliefs about the legitimacy of the racial status quo, predicted opposition to the BLM protest movement, to opposition to affirmative action, and opposition to reparations. These system justifying ideologies also predicted exclusionary racial policies, things like border fortification, family separation, and Muslim registries. So we encourage experimental and cross-sectional research using racial system justification to examine social policy, collective action, intergroup behavior, and well-being. Okay, and so remember that I kind of ended the first part of my talk by saying we need to be more open to the idea of civil unrest and collective action and protest behavior. So we want more openness there, right? But at the individual level, right, we should challenge notions that the system is fair, whether the general system is fair, right? Whether the racial system is fair, whether gender relations in this country are fair. We need to challenge those notions, right? And so in terms of policy recommendations, we might want to consider things like removing just framing from terms like the criminal justice system, right? So increasingly, you're hearing people say things like, or use terms like the criminal legal system, right? We may also want to do things like frame racial equity reforms as system upgrades, okay? So as we're trying to make improvements, right? Understand, right? We've come a long way since MS-DOS, haven't we? Right? We've come a long way since Windows 98. We've come a long way since Windows 10, right? And in that way, right, we can see the benefits of upgrading a system that, if imperfect, maybe has some good things to it, right? And then finally, with respect to policymakers, I might encourage, all right, self-affirmation interventions to stabilize one's self-structure, right? Which under threat, right, when we are hearing things, right, criticisms of the racial status quo, right, could make us defensive, right? Right. And so I don't want policymakers to see discontent from Black Americans, right, and with the stroke of a key, label 30 million of us as racial conspiracists. Okay. But I'll stop there. Thank you very much for my time today. It's really been an honor and pleasure. Thank you.
Anything coming? So this is the time for questions here.
Paula said that Black Americans are conspiracy theorists. Is it actually just that they're more educated on?
Right. Yeah. So right. So the general idea is, right, that is another possible interpretation, right? And you know, I wanted to find a way to maybe link my talk to the idea of like narrative medicine, right? And like what is being said versus what's like not being said, right? And so I think there was some kind of gap, right, in terms of like what was being said and what was not being said. Because the people that were being sampled are very clearly suspicious of these American institutions, as they've probably rightfully should be, given the ample evidence of how these systems have harmed Black Americans, right? And they're probably going to be much more in tune with those historical facts, right? Maybe even than the pollsters, right? That are designing those questions, right? And so I think something about that dynamic makes it easy for them to dismiss this group that they instead really should be listening to, right? Which is the part of the idea of like narrative medicine, right? Then maybe there needs to be like narrative polling, right, where you understand like what are these people saying, right, rather than kind of dismissing it with a very basic interpretation.
I think your point earlier about people are often motivated to defend the status quo. I think that article title is a good example of that, because you would have expected it might be maybe something like African Americans. The study highlights how African Americans have been failed by institutions. But the people who wrote the study don't want to talk about how the institutions have failed minorities. So it's reframed to protect the status quo.
Right. And so almost it's what you might be saying is that the Black Americans that were sampled, they're telling the truth, right? These posters, right? When that truth was laid bare, they were afraid to repeat the truth, right? So they altered that truth.
They couldn't see it.
Right. I meant to just get here, right? They couldn't see that truth.
A comment question.
Sure.
I was really struck by the where racial system justification and general system justification didn't align. So one thing I kind of wondered about some of the question that they didn't align made me wonder that maybe that it made it clear that there is like a really big racial component to some of these questions, like building a border wall, separating families at the border. I'm curious where you see racial justification and general justification aligning more.
That's a good question. I do think that there are places where they're going to converge and where they're going to diverge, right? I have to say, myself and one of my collaborators and colleagues, John Jost, who developed system justification theory, we're very curious about these findings, and we're still kind of scratching our heads about what they mean, right? And it seems that when racial issues come into play, right, racial system justification is powerful, right? But I think that and though we ultimately contend, right, that variability on racial system justification is going to be associated with seemingly non-racial things, right? So like when people think about climate change, they don't necessarily think about it as a racial issue, right? But they're not thinking about like the millions of brown people that are being displaced in other parts of the world, right? And sometimes that's going to kind of manifest itself in terms of scores or the examination of racial system justification in climate change versus general system justification, right? So I might give that as a case where I might expect those scores to diverge, right? Maybe with respect to economic issues, maybe I'm likely to see more convergence. But that's a really good question that I need to think about. Another question over here.
They converge differently, race more specific. Like as someone who has seen the system justification scale, if you don't have like a theory of system justification or race, that might seem like I don't really think about this in that way. But then if you involve race, then that's a very specific example that I can respond to more active.
I think that's a really good point. And I have I'm not going to try to. I have a colleague who studies just that, and I'm not remembering his name right now, so I don't want to butcher it in a public presentation. But we're generally curious about domain-specific measures of system justification, and think that these domain-specific measures are often going to be more predictive of things within that domain or that context, right? And so I think you raise a good point. When you read the general system justification items, right? They essentially say like, America is the best place in the world to live. this, I think that is nearly one of the exact items, right? So you might be thinking a little bit about patriotism. You might be thinking about the functioning of the country, right? But when you start to think about gender relations with respect to the gender specific system justification measure, right? You really begin to start thinking about sexes, right? When you read the items on racial system justification, you're probably going to start thinking about racism and systemic racism, right? There is also an economic system justification measure. That was actually the first system justification measure, right? And I think we would expect that, like, economically, when people are thinking about Occupy Wall Street or relevant economic movements, that the economic system justification scale will probably be more predictive of variability there. So, that being said, I do think there are probably cases where the general measure is better, but I think increasingly system justification researchers are using more fine-tuned measures. Right. All right.
Get over here. Yeah. Ben, thank you so much for that. I think we could just say, I think we could probably take questions forever. Just make sure. Okay. All right. It is my pleasure. Oh, I just stopped.
Okay.
So, where are we to? It's my pleasure to introduce our next speaker, licensed clinical social worker, Ariana Drakatos-Schindel. With more than 20 years of experience in global public health and human rights, she has led grassroots, peer-driven mental health, staff care, and health and labor justice initiatives across U.S. and international contexts. Most recently, their work has focused on supporting immigrant and refugee communities through Cornell University's Worker Institute, local and national labor unions, and the RISA Collective, a women-led organization using storytelling, healing, organizing, and research to advance social transformation and environmental justice.
Thank you so much. Can you all hear me okay?
Yes.
Okay. Despite these incredible presentations, I'm going to take the narrative justice license and actually just tell you all some stories to share a little bit about the work that we've been doing. Again, my name is Ariana, and I want to thank the Spicy team for all their incredible work, and Dr. Saunders and Dr. Dasgupta for creating this framework for us to step into and to really think about what is possible, right? I hope this presentation helps you think about what possibilities we have inside of these systems. And I'm just kind of naming in the name of narrative humility, as Dr. Dasgupta talked about, right? I don't understand. I try to understand. I don't understand anyway. Like, that framework is that I'm a conduit for talking about programs that are led by other folks in community. And so I'm sharing just some of the lessons from their wisdom and their skills as I stand up here. And hopefully you can learn more about the work and hear directly from them yourself. And I think just thinking about doing some narrative justice, I want to start the conversation with kind of my own story, how I came into healthcare, what that meant for me, how I came into activism and organizing. And I will kind of start, I was just thinking this morning about my first experience with kind of the injustice of the healthcare system. And I was really little, and we would get these phone calls. It was like the phones that had the cord, they bolt to the wall. Okay, I'd get the phone, I'd pick it up, and it'd be like, collect call from Creedmoor or from another facility. And then I would hear this voice, and it was like a very strongly accented, Tiganis Koritsimu, how are you, right? And it was my aunt calling me. And she was the one who had supported my mom and my family during World War II. They grew up in Greece. It was like very violent for them. The women held it down, as is often the case. And then when she came to the US, there was the tragic accident with her husband, and she claimed because they were immigrants and couldn't speak English that they didn't get the health care they needed in time, and he died in her arms. So all of these kind of systemic factors of immigrants arriving, and there's intersectional identity and all kinds of different issues, led to her kind of mental health breakdown, and the system is not being able to hold her. And despite my family's best attempts, we lived far away, my family's best attempts to create a system of care, she was locked up in a violent system, right? That saw her as a number, that saw her as a danger. And so that was a really early experience of what I thought mental health meant. That's what I thought healthcare meant. And that's what I thought would happen to my people, right? And so that shaped deeply, I think, the path I took. I was organizing since I was a kid, but it also shaped my path into healthcare. And so
You're back up.
Okay, cool. Hi, y'all. We're just figuring out where I can jump back in. Welcome back. Should I just go?
I'm just seeing if anyone will tell us where we lost. Okay, everyone, they're saying we're back up, which is great. But I want to see if anyone knows where we lost you. Oh, but not basically not at all. Like, yeah. If you want to like kind of say the results, like the
Great.
yeah. So
What was my punchline? Yeah, right. Okay, so we were talking about the work in Myanmar about these backpack health workers, teaching Indigenous youth, knocking on the door, understanding that we have been often deprived here of systems of collective care, peer-led systems that build on the collective resilience and strategies of our communities. And so these groups were deeply grounding and helping teach me about what is possible in healthcare. One, to your point, Dr. Saunders, that healthcare lives inside of social movement spaces, that we cannot separate health from the larger issues of justice, from narrative justice to justice in our streets. And so the examples I'll talk about today are all based in social movements. And the reason that is the core of my work is because those are often the communities that are experiencing high levels of marginalization, have often most access to other communities, and are often really disenfranchised by the systems. And so back to these kind of backpack health workers, there were some really important constructs that they taught me. One is the real structures of co-creation, right? And so the programs that were being run by Indigenous youth, right, were co-created by them. They knew not only how to navigate the dangerous areas where their communities were living, but they also knew how to talk about malaria with their communities. They knew how to apply the medicine. They knew the cultural practices that would impact it. So the only way that those processes could be effective is if the youth were actually co-creating them. And they weren't just being consulted and taught. They were literally designing the programs and coming back from the field and saying, this is what we do. Right. The second piece is this kind of peer-based decentralized model of healthcare, which is so crucial in these environments. And really, it feels like there's no choice if you don't have access to kind of these healthcare infrastructure, if you're in low resource settings. But the power of these models is that it is an ever-growing, ever-evolving model, right? So those youth then went on. I went back a couple months after the project finished, and they were now carrying around in the field these pink bags of plastic. And I was like, what is this? They were making prosthetic limbs on site. They would just like have this little machine that they would carry into the jungle, fire up, and they would be able to fit people with prosthetic limbs, right? These are 16-year-old young people, 17-year-old kids, right? And they kept evolving. Some of them went on, there was training that would come into these IDP camps. Some of them learned to do eye surgery, right? And they were teaching others. So it was not just that group of youth, then more youth and more were trained, right? So these decentralized peer models are not only important because they offer care, but because they built a continuum and a growing network of care that is necessary to meet the ever-growing need of our communities as they face all these systems of oppression. Okay, and the last thing these young people taught me, and I was quite young at the time myself, so was kind of how do we shift the colonial logics of care? And that's, that we can unpack that in a lot of different ways. But particularly in these communities, there was a way that care needed to be delivered that was attuned to cultural practices. So just to give an example, we would get supplies into this base area. And culturally for the Karen people, if you keep a lot of stuff, what do you think that means about you as a person? If you hoard a lot, if you have a lot of items, what does that say about you?
selfish.
You're selfish. Okay. So these backpack health workers were like, yo, we cannot have all these things in our community because people will see us as hoarding, even if we're resourcing ourselves. right? And lo and behold, when the aid trucks start coming in and the area opens, what do? They drop off tons and tons and tons of supplies without a cultural consciousness measure or a structural competency measure for how care needs to be delivered. Other factors, right, are of course like the interconnected systems of care. Can people listen to Indigenous young people? Who else needs to be consulted? How do we understand hierarchies and cultural kind of intricacies of how care gets delivered? And then deepest part is that they were constantly integrating their own wisdom and knowledge, right? And so they might be talking about malaria, but they're also bringing in Indigenous practices, right? And that's a fluid process because they're the ones co-creating these systems, yeah? Okay, so I'm young, I'm 20, this is what I learned healthcare can be. And so I decide to go study public health and become a licensed clinical social worker so I can work on a systems level around this stuff, right? It was so different than the experiences that I had growing up and that I witnessed happening to folks in my community. So I want to share with you a couple of programs that we have created kind of in service of some of these lessons. And the first one I'll tell you for our global folks is a program called the Fire That Fuels. I have a small collective organization called RISA, and we work in this program around the world. The idea of Fire That Fuels is if we are activists in social movements, we have a fire that fuels us, but we don't want it to burn us out. And how do we sustain ourselves inside of these movements? And this work kind of came from actually some research that we got called into almost a decade, more than a decade ago, by the Human Rights Resilience Project. They were at Columbia and NYU, and they were looking at the rates of PTSD in human rights activists around the globe. And they were looking at them, and at the time, they were seeing rates that were as high as like returning combat veterans. And they were like, what do we do about this? These folks are not accessing mainstream systems. These folks are in contact with tons of people. These folks do not have any kind of, there's no knowledge around these kind of very westernized concepts and pathologizing concepts of their health and well-being. So how do we create what we call regenerative systems of care? And so Fire That Fuels began with a group of activists and clinicians and people in a room together trying to kind of figure this out and testing it out in different communities that they were a part of. And the model grew in some really important ways, and now it's like 10 countries around the world. We have cohorts that build out this model and replicate it. And the idea is that what we need to do when we're thinking about mental health as a construct is thinking about it in the framework of collective trauma and collective power, right? If collective trauma is a wound to our safety, our worth, our sense of connection, our imagination, then our collective regeneration has to be a reclamation of those things. Yeah. And so what does that look like in practice, right? Because if you try to get a bunch of frontline journalists from Honduras into a room to talk about their mental health, your room will be empty. I'll just name it, right? But if you say, we are being oppressed by these systems that impact how we feel about ourselves, the relationships we have, and how we build power, like, okay, tell me more. And what they end up doing is taking part in a training program, which I'll tell you a little more about in a moment, and then developing out of that training program regenerative practices that they build into whatever site that they're working in. So the journalists in Honduras, for example, were holding these, they were very, 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 very under threat by the state. So their offices were constantly being raided. So they have these underground meetings with journalists where they would be talking about political issues. And then they started what we call these regeneration circles, which are basically kind of support groups, community care circles that they got trained to facilitate and developed programming around. And so every time journalists would gather, they would actually start with a care circle. That would be the first piece of what they did. And they said it built deep and different relationships than they had ever had because it rebuilt trust across the movement that had been fractured, right? Groups in Uganda, which is a huge place. We work with LGBTQ activists in Uganda, and a coalition of activists developed this system that we started in 2017, and they still have programming. I really wish one of them could have been here today to speak with you. But they developed this regenerative model. And the idea of Fire That Fuels and the principles is that they are adaptable, right? And that they have some core kind of values that carry forward, but they bring the culture and constructs of whatever space that they're being built into. So the community began to do these amazing like parties, they called karaoke's, where they would bring activists together underground, right? Very dangerous in Uganda to be an LGBTQ person if you don't know the context. Mostly US-based kind of homophobia that was shipped out to the Ugandan parliament. Okay, very dangerous. So they are gathering underground, they're having these kind of dance parties, and then one of the regenerators that we've trained works with the DJ at the party, and they curate a musical list and a set of practices that's about dancing and then reconnecting with body and self and discovering the parts of self that have been harmed and claiming body and connection with other people, right? And through these dance parties, which is one example, I'll talk about more, they were beginning to do practices of reclaiming safety inside of an environment that will never be safe for them, right? Which is the context of doing mental health in a constantly highly traumatized, high security environment, right? Nobody will ever be safe. Nobody will ever be fully belonging. No one will ever have any of those things. So we have to be able to create those conditions inside of the spaces that they're in. So these kind of cohorts come together. The current structure is they do a 4-day training. They move through this process of safety, worth, connection, imagination. They reclaim those. We talk about the externalized security states, right? That harm us, many of the conditions and the factors of systems that you were just talking about, right? And then how those become internalized inside of us and our systems and how they break down into our mental health, into how we feel and how we relate to others. And then they build out these projects that I named. And the incredible thing is that there's very little funds available for this. And like we worked with domestic workers during COVID particularly, and they were going to take care of other people's families, clean other people's houses. If you don't know, they're some of the most marginalized workers in the US, largely immigrant women and women of color, who many are undocumented, right? And so they're very much frontline workers. And so they're going in and we're seeing high rates of people dying, right? We're seeing a lot of fear, very, very high levels of precarity, right? They're not getting the social safety nets to support them. So they start these kind of circle processes, these regeneration circles. They start them online. They do them for, we had an eight-week curriculum that they developed. They did them for 2.5 years. No resources. They just ran them. And they are still running them and they're creating new programs, right? And they've evolved. And so part of Fire That Fuels is we call it a network of building regenerative movements because the trainers come from the community. Once they've gone through the program, they become the trainers. They carry it to their community. They connect with other folks. And so it's an ever-growing network of building this regenerative healthcare model across these different contexts. And I'm going to try to be short on time. Talk too much. And I'm just like hearkening back to kind of these lessons that I learned from the backpack healthcare workers, right? And the systems that I saw were so harmful as I was growing up, which is that if you have peer-based models, if you help build systems that are adaptable, if you allow people to kind of deconstruct the colonial notions of healthcare, particularly mental health, and have people imagine what that means in their own context, their own reality, and their own lived experience, they can create programs that sustain and last and build and grow, right? And move outside of the expert models. And because I know we're talking to healthcare policymakers, a big piece of what we ended up doing, particularly in Uganda and Sri Lanka, was helping folks then also interface with the mainstream healthcare systems, right? Because there was so much discrimination. In fact, like not just discrimination, but sometimes incredible violence that was done, particularly when trans folks would enter a healthcare system in Uganda, for example. The team there, because they developed the program, decided, okay, we're going to create a whole network that can interface and like accompany people as they go to the hospitals, teach them about our communities if they enter into any kind of institution or long-term care. And so part of the model was also then in places where it is relevant, where there are care systems, to interface with those care systems, create advocacy, and create accompaniment models that allow people to have a more just experience inside of those systems. Okay, so that is the fire that fuels. We currently have a cohort here with care workers from across New York City, so nurses, domestic workers, home care workers, many of the people who are the fabric of our communities and who are feeling particularly the tensions of this moment. And so the second example I'll use is just to talk about how we're supporting folks in their interactions with ICE. And so we work a lot with immigrant communities. This is particularly for my work with Cornell. And we have, as many of you have thought about, noticed that there's fewer numbers of people going to clinics. People are scared to leave their house. We have folks who haven't left in weeks. We had a home care worker training that got raided just at the end of last year, right? So this is New York City. There's not safety for folks, right? And so again, what do we do to embed mental health and healthcare inside of people's existing systems and frameworks? And what does that look like? So because some of our other work is thinking about know your rights training, rapid response training, we decided how can we embed that into these systems? And so we have a network of peer trainers who are domestic workers and care workers and other folks who are from these communities who are giving these know your rights trainings. And so if folks have gotten one, and if you haven't, you should, there's a little red card, that's your rights card, that gives your legal rights on it. And so people have learned to carry those around and present them with the police or if ICE comes to your door. So we made a yellow emotional care card so for each of the rights that's inside of the legal framework, there's like an emotional regulation tool, there's a response tool that folks can have in order to ground themselves, to be able to take space, to be able to reach out for support. Because what we found is like, it didn't matter if people knew their rights, if they were in shutdown mode, right? In the moments when they were confronting them, then actually they weren't able to enact even their own safety and protection. Yeah. So the training also includes lots of different kinds of regulation, meditation, all kinds of practices and care practices to help people understand how they're doing, rate their distress levels, things like that, and to be able to then look towards care and support from their communities before those levels get too high. We've also been working a bunch in Minneapolis. I was down there helping organize for the general strike, but while doing that, of course, folks were like, we need care. And so in these trainings where we're doing de-escalation, we started doing practices around emotional first aid, right? And so SOS kind of, how do you support people who are in emotional crisis? When someone literally gets killed right in front of you, what is the mechanism to help bring people back? How do we manage the group? How do we manage ourselves? And so we've integrated into all these activist groups that are doing these trainings, these kind of care practices and this kind of mental health learning that's adjusted for how folks can hear it and respond to it who are working actively inside those communities. And then the last kind of piece that I think I want to touch on, the last example is kind of a systemic example that's a little bit different. It's through the work at Cornell that we do. And this is when we were approached by I'm trying to remember now. I think it was the Times. There was a big article that came out that was like epidemic of suicides among taxi drivers. Somehow whenever anybody says epidemic of suicide rates, we get a call. So here we go. So this was like about 8 or 9 years ago. And I don't know if y'all remember, but there was a very prominent suicide where a driver committed suicide and then was like on the steps of City Hall and left a note basically saying, the system, being a worker has caused this to happen, right? And drivers, Uber, Lyft, and taxi drivers, largely immigrant men, face an incredible amount of precarity. They're working 12 to 15 to longer days. They don't see their families. They almost, particularly with Uber and Lyft, with the biggest companies, often don't break even. They're massively in debt. They're isolated in their cars. They're unwell in so many ways. And so we were seeing these really high rates of suicide. And so the question was like, what kind of program can we create that will support reaching these drivers who are very hard to reach because they're in cars running around all the time, right? And so we built a wellness program that began in 2 ways. One is a peer-based program that uses culturally created WhatsApp groups in about 20 different languages to kind of bring this knowledge to drivers. So other drivers who are trained as peers are using WhatsApp groups to offer health and wellness knowledge. And then there was a series of trainings that we ran, and then we developed kind of multicultural team of counselors who's able to give services to any driver, any member of their family that wants access to those services through the union, which is very powerful. And then a similar problem happened. Maybe you all saw the other Times article that was like mass suicide rates in the construction industry. Again, a largely male industry. The rates of suicide are about 5,000 a year, which is five times more than the kind of workplace injuries, fatalities all combined, right? Falling off buildings, getting caught in between things. Suicide is the highest workplace fatality. And it's happening on the job. So people are going to work and they're walking off a building. Intense stuff. And this is a group of largely men with a culture, a very heteropatriarchal culture that really is not going to invite in these kind of conversations. And so they created a peer program called the Building Trades Peer Support Network. It's getting its final launch March 1st, so wish us luck. And that will train 100,000 building trade folks, so 100,000 construction workers across New York City, in a destigmatizing curriculum that's taught by their peers, that's been co-developed by them, to use the language and issues that most matter to them. And then they'll train 1,000 peer supporters in the first year, so that every job site in the city, wherever you stop and you see someone working, there will be someone offering peer support. And doing it in a way that acknowledges many of the issues that we've kind of talked about, that we need to understand people's internal resilience, their capacity to care for one another. And I will just say, in the early pieces of this training, we've just been piloting it, everybody cried. And I was really shocked, because when I got in, they were like, what the fuck is, you know, they were like, why are we doing this? And then the next thing I knew, people were in tears, and it was so powerful. And particularly in these political moments, as we see the intense pressure that our communities are facing, the capacity for our movements and our advocates, policymakers, and activists to take on the framework of how do I create policy, how do I create programs that build the support of peers and the knowledge of communities, that understand the structural competency that's needed to build those programs, and understand where the attacks and the source of a lot of that trauma and pain is coming from. And we can actually resource the people who have the skills and capacity to make this change. They're there, they're everywhere. Every construction worker, every single driver, every single Indigenous youth, all of them have the capacity for this transformation. And if policymakers and if program managers can design and think about programs in this way, we can reverse some of these systemic issues that we've seen, and we can build the world that we haven't seen yet, right? We haven't gotten there yet. Many of us have lived under a crumbling democracy that didn't serve lots of people. We're living in a different moment right now. And yet there's a world that we can build, that it's on its way, that is breathing. And so thank you so much. I'll end with that. I think we just have 5 minutes.
Questions or comments? We're going to shut down the
Any
session.
questions on online too?
I'll let you know. Nothing online. But comments or questions here in the room? Very inspirational. Oh, wait, a question. Nope, you got one.
This is a very general question. I just want to say, well, maybe actually I'll say a couple of things. One, I was very locked in on your presentation, and you had me glued completely. Two, I appreciate that kind of ended maybe kind of with this idea of like utopic thinking and imagining ideas that we can't see, the power of that. But I guess my question is really, because I was so inspired by what you do, yet see it very far away from where I am in academia, is like, you know, how could nerds be helpful in that context? I suppose.
Nerds are so helpful. I also work at corn, so it's okay. I'm there too. Yeah, I think, you know, what was very helpful is that folks evaluated our programs for us. So the Fire That Fuels program got evaluated with our folks in Uganda. And when you do evaluations on programs, people who are policymakers, am I supposed to be here? Okay. Just as an example, when you do evaluations on programs, people start to care about them who are at policy levels and start to say, let us invest in the people who actually have the capacity to make the change. And so I think there's a big piece. And then how do we analyze the issues? I mean, your presentation was incredible because you helped us lay out all these different systemic factors and the interrelationships and complexities of them and how to intervene on them. And I think programs are only going to be successful if they can use that kind of analysis, right? And bring it to communities to do their own assessment. I mean, a lot of communities feel this, right? We can give them a piece of paper, but they feel it, but they may not be able to hold the context of what are all the intersecting pieces that are impacting them. And no program will be successful without actually looking at the systemic roots of things. And so I think there's a key role in like one, uplifting programs that are doing it and getting kind of the analysis to people in an understandable way who are on the ground making those things happen so that communities can have access to that. Because I mean, even just Minneapolis, if you think about their rapid response network, there's a whole bunch of data nerds who are like running that system. One, so it's interconnected, so the right decentralized nodes are talking to other decentralized nodes, but also because there's like all these hackers who are trying to hack into the systems. And so there's a whole way that there's all the skills that everybody brings have a key role to play, particularly in the moment that we're in. So yeah, I would just say there's many more ways, but just those are just a few that I think are important.
Maybe time for one more question or comment. Thank you so much. Running up against time, but I do encourage you to stop and take food home or drinks home. They are paid for by SPICY. They are yours if you would like. The norm is established. It's okay to do that. So have cookies, bring things home. Thank you so much for attending. We will have a recording of the session and make it available. Thank you so much.